I apologize for any background noise. My little one is playing with a toy. So my name is Rebecca Harrison. I'm a nurse practitioner in the heart failure clinic at Yale New Haven Hospital in the outpatient setting, and I'm going to be presenting to you the cardiovascular and peripheral vascular exam. So the purpose of the cardiovascular and peripheral vascular exam isn't just about listening to the heart and feeling pulses. It's about detecting patterns that tell you how the entire circulatory system is functioning and whether your patient's body is getting the oxygen and nutrients it needs. This slide goes over the techniques, findings, and relevance of each individual part of the exam when we talk cardiovascular and peripheral vascular. As we all know, we should be inspecting our patients, palpating their skin, their pulses, their chest wall, and then auscultation of the heart and the vesicles, listening for normal heart sounds, any abnormal heart sounds, and bruits. And then last that we talk about is percussion. In the cardiovascular exam, however, this is a less common practice. It would be done along the cardiac borders in order to assess for dullness. However, given the prevalence of imaging, we now mostly turn to imaging to assess for cardiomegaly. Some special tests that you'll see, Allen's tests. If you're working in hospital, you may have seen this before. This is to ensure safe radial artery puncture. ABI will quantify PAD severity, and the Trendelenburg test will identify venous insufficiency. Observations for peripheral vascular disease would be hair loss, shiny skin, pallor on elevation, dependent rubor. Those are all going to be arterial indications, while venous indications will be hyperpigmentation, edema, varicosities, ulcerations above the medial malleolus. The clinical relevance for that is when we're looking at arterial, we're looking for ischemia, which may lead to amputation. Conversely, chronic venous stasis may lead to recurrent ulcerations. Ultimately, what I'm going to tell you regarding the peripheral vascular and cardiovascular exams is that you need to link the physical signs to the patient cardiovascular risk profile. A smoker with diminished dorsalis pedis pulses should have a high suspicion for peripheral artery disease, while a hypertensive patient with an S4 gallop probably has left ventricular hypertrophy or diastolic dysfunction. We'll get more into each one of these as we go throughout the slides. The cardiac chambers, valves, and circulation of the blood. I'll go over this in a couple of different slides, but ultimately, deoxygenated blood comes from the body into the right atrium, which then goes through the tricuspid valve into the right ventricle, out of the right ventricle through the pulmonary valve, pulmonic valve, out into the pulmonary artery to the lungs. The lungs then bring it back through the pulmonary veins into the left atrium, through the mitral valve into the left ventricle, and then out the aortic valve into the aorta and out into the systemic circulatory system. This should be a review for everyone. Additionally, a review, events of the cardiac cycle. In S1, it's the closure of the tricuspid and mitral valves leading into systole, the closure of the pulmonic and aortic valves, signal S2, and the lead into diastole. And we just continue that cycle, the closure of tricuspid and mitral, S1, systole, closure of pulmonic and aortic, S2, diastole. Circulation pathway. The pulmonary circuit and the systemic circuit are functionally distinct. The pulmonary circuit is optimized for efficient gas exchange at low pressure with high blood flow. Conversely, the systemic circuit is designed for nutrient and gas delivery at high pressure. So the separation of these two circuits is essential for maintaining the integrity of the blood-gas barrier and for the overall efficiency of cardiovascular function. Again, this goes over the circulatory system in yet another way. So oxygen poor blood comes from the body through the right side of the heart out into the lungs. Oxygen-rich blood comes from the lungs through the left side of the heart and out to the body. The peripheral vascular system encompasses the assessment of arteries, veins, and lymphatics outside of the heart and brain, with particular focus on the lower extremities due to the high prevalence of peripheral artery disease. A review should include evaluation of anatomy, vascular anatomy, physiology, and pathology, and most commonly atherosclerotic disease, but also venous disorders such as chronic venous insufficiency and DVTs. So when we talk to people in the cardiovascular and peripheral vascular system, we're going to pull a health history. This is just talking to your patient, and this is approved by the American College of Cardiology, ACC, and the American Heart Association, AHA. So this is all recommended by these two organizations, which is where I mostly do a lot of my own work, and my colleagues in peripheral vascular do a lot of their work as well. So cardiovascular systems, we should be asking patients about chest pain or discomfort, dyspnea, palpitations, syncope or syncope, orthopnea, paroxysmal nocturnal dyspnea or PND, lower extremity edema, and these should all be documented in the old CARTS fashion. So onset, location, duration, characteristics, any alleviating or aggravating symptoms, and then any treatments that they've used. Also, we should be talking to them about symptoms of exertional leg discomfort. These can be indications of claudication, which can be aching, burning, cramping, or fatigue. And again, old CARTS, and for location, you should be talking to them about their buttocks, thighs, calf, ankle, and whether or not those symptoms are relieved by rest or require prolonged recovery. Non-joint related exertional lower extremity symptoms or impaired walking function, including leg weakness, numbness, or fatigue during walking. Ischemic rest pain and history of non-healing or slow healing lower extremity wounds. History of lower extremity gangrene or other ischemic skin changes like asymmetric hair growth, nail bed changes, calf muscle atrophy, elevation pallor, dependent rubor. Erectile dysfunction in males is a marker of vascular disease. Cardiovascular risk factors, these are going to be hypertension, dyslipidemia, diabetes, obesity, current or former smoking history, physical inactivity, poor diet, sleep health, chronic kidney disease, family history of atherosclerotic disease, and prior cardiovascular or cerebrovascular events. The heart and the brain are connected. Poor sleep health can also be a cardiovascular risk factor, so we should be assessing these patients for obstructive sleep apnea or obesity-related sleep apnea. Family history of anything ASCVD, sudden cardiac death, inherited cardiac conditions like hypertrophic or dilated cardiomyopathy, prolonged QT syndrome, Marfan syndrome, and then any disability from heart disease in a first-degree relative. Medication and supplement history, including over-the-counter agents that may affect cardiovascular status. These are your Sudafed users. A review of prior cardiovascular workup and interventions. So this should include any and all previous imaging, procedures, and treatments. And then lastly, assessment of walking impairment, claudication, ischemic rest pain, and non-healing wounds, and those at risk for peripheral artery disease. So a little bit of that was a duplication, but cardiovascular and peripheral vascular systems are connected, and you should be assessing your patients for all of these. So this is the cardiovascular exam. Like I said, we start with inspection of the chest wall for deformities, visual pulsations, any signs of heart failure like peripheral edema or cyanosis. Then we're going to go into palpation, so assessing for the point of maximal impulse, percordial heaves and thrills, palpate peripheral pulses and compare for symmetry. Diminished femoral pulses may suggest aortic coarctation. Evaluate for edema and assess jugular venous pressure to estimate central venous pressure and volume status. This is something I do every day, and it's imperative. Systemically listen to all cardiac areas for heart sounds, extra sounds like S3 and 4, murmurs, and murmurs should be characterized by their timing, location, intensity, and radiation. Friction rubs may indicate pericarditis, the presence of S3 is associated with heart failure and poor prognosis, while S4 may be present in hypertensive heart disease or left ventricular dysfunction. Regarding JVP, you are going to learn the assessment. I will tell you that this is imperative in my practice because I'm assessing heart failure patients. For your primary care assessment, JVP is something that it takes a very long time to learn. It's taken me years to perfect it, and it's one person's. It's a judgment thing, and it even takes the attendings many years to develop a good assessment of the skill. Blood pressure measurement should be in both arms to detect discrepancies suggestive of aortic dissection or coarctation, and orthostatic measurements can identify autonomic dysfunction or volume depletion. Special maneuvers are assessment of HJR or hepatojugular reflex, the Valsalva maneuver, and carotid sinus massage. Those should only be done when indicated and with appropriate precautions, and these are mostly to evaluate for heart failure, arrhythmias, and syncope. The left lateral decubitus position enhances detection and characterization of certain cardiac findings, particularly low-pitched extra heart sounds like S3, S4, and murmurs originating from the mitral valve. This is the same position that we put people in for echocardiography. In this position, the heart is brought closer to the chest wall, especially the left ventricular apex, which optimizes auscultation at the apex with the bellow of the stethoscope, and it increases the sensitivity of the physical exam for detecting subtle mitral valve pathology and abnormal ventricular filling sounds, which may be missed in the supine position. Again, all of this is recommended by the ACC and AHA. The peripheral vascular exam. Again, palpation of the lower extremity pulses, femoral, popliteal, dorsalis, pedis, and posterior tibial to assess for defects, auscultation for vascular bruits in the epigastric, periumbilical, and groin regions, particularly over the femoral artery, can reveal proximal arterial stenosis, inspection for any non-healing wounds, gangrene, and other signs of ischemia like asymmetric hair growth, nail bed changes, calf muscle atrophy, elevation, pallor, or dependent rumor. Any findings can help identify peripheral artery disease and its severity. Any abnormality should be further evaluated with ABIs. The rationale for recommendations and physical signs may be subtle and absent in early disease. Systematic examination increases diagnostic sensitivity for clinically significant peripheral vascular pathology. The examination is further informed by evidence from diagnostic accuracy studies and clinical practice, in addition to pulse palpation and inspection for ischemic changes. As I've mentioned previously, we should be looking at skin abnormalities like pallor, rubor, cyanosis, and trophic changes, which would include atrophy, hair loss, and brittle nails. Those are indicative of chronic arterial insufficiency. Ulceration patterns like dry, painful ulcers at the toes or lateral malleolus suggest arterial disease, while painless ulcers at the medial malleolus are suggestive of venous stasis. Capillary refill time, venous filling time, and temperature differences between limbs are additional markers for impaired perfusion. Diagnostic accuracy of pedal pulse palpation is high, with sensitivity exceeding 85% for ruling out PAD in at-risk populations. When pulses are difficult to palpate, a handheld Doppler should be used. So the following figure illustrates the anatomy and technique for palpating lower extremity pulses and obtaining ABI measurements, which are central to the physical examination and diagnosis of peripheral vascular disease. The Allen test, as I mentioned earlier, that's a bedside maneuver used during the peripheral vascular exam to assess for the adequacy of collateral circulation to the hand via the ulnar artery before procedures involving the radial arteries, such as arterial cannulation or harvesting. So if you've ever seen somebody put in an A-line, they may be doing this test at the bedside. The test would be to have the patient elevate the hand and make a fist for 30 seconds to exsanguinate the blood from the palm. The examiner would then simultaneously occlude both the radial and ulnar arteries at the wrist, resulting in a blanching of the hand. The patient then would open the hand, and the examiner releases the pressure on the ulnar artery while maintaining occlusion on the radial artery. And the time required for color to return to the palm is observed. Normal would be within 5 to 15 seconds. The Berger test is also, I called it the Trendelenburg test earlier. It's a bedside maneuver used during the peripheral vascular exam to assess for lower extremity arterial insufficiency, particularly in the context of suspected peripheral artery disease or chronic limb-threatening ischemia. I've worked in peripheral vascular and cardiovascular for a long time. I have not seen this done very often. The test evaluates the presence of elevation, pallor, and dependent rumor, which are classic signs of impaired arterial perfusion. So the patient will lie supine. The examiner elevates the legs to a 45 to 90 degree angle for 1 minute to 2 minutes. If in the limb with normal arterial supply, the foot remains pink, but if the development of pallor on elevation would suggest significant arterial insufficiency. Leg is then lowered to a dependent position, and the examiner observes for return of color. Delayed return of color and the appearance of a deep, ruddy red hue is also called sunset foot, is indicative of severe ischemia. A positive test is when pallor appears at angles less than 20 degrees, indicating critical ischemia. So normal findings in the cardiovascular exam are normal heart rhythm, normal S1 and S2 without extra sounds. A physiologic S3 is a normal finding in healthy children, adolescents, and young adults, and it reflects rapid early diastolic ventricular filling in the context of compliant ventricular walls and high cardiac output. Point of maximal impulse should be located at the 5th intercostal space at the mid-clavicular line. There should be no murmurs, rubs, or gallops. JVP should be within normal limits. We say approximately 5 to 8 centimeters. Peripheral pulses, carotid, radial, femoral, popliteal, dorsalis pedis, and posterior tibial should all be palpable and symmetric with no bruise on auscultation. Skin should be warm and dry with normal color and capillary refill time. There should be no edema. Your peripheral vascular exam should have palpable symmetric pulses in all major arteries, absence of bruise, normal skin color and temperature, intact hair growth, no ulcers or wounds. Capillary refill should be brisk, less than 2 seconds, with no trophic skin changes. Abnormal findings in your cardiovascular have direct clinical implications. In the cardiovascular exam, irregular rhythm, extra heart sounds like S34, murmurs, displaced point of maximal impulse, elevated jugular venous pressure, or peripheral edema may indicate heart failure, valvular disease, arrhythmias, or volume overload. Diminished or asymmetric pulses and bruise suggest atherosclerotic disease or vascular stenosis. In the peripheral vascular exam, findings such as diminished or absent pulses, vascular bruise, non-healing wounds, gangrene, elevation pallor, dependent rubor, and trophic skin changes are highly suggestive of PAD or critical limb ischemia. The ACC and AHA recommend that any abnormal findings should prompt further evaluation, typically with an ABI, to confirm PAD and guide management. So this is a chart that I made for the various types of murmurs. So for aortic stenosis, that's a systolic murmur that you would hear on the right upper sternal border. It would radiate to the carotid arteries and the apex of the heart. It's a harsh crescendo decrescendo, which increases then decreases, and it's a narrowing of the aortic valve. Pulmonary stenosis is a systolic murmur, left upper sternal border, slightly toward the neck, not as wide. It radiates slightly toward the neck, not as widely as aortic stenosis, however. It's a harsh crescendo decrescendo, and it increases with inspiration. It's a narrowing of the pulmonary valve. A mitral regurgitation is also a systolic murmur. This is located at the apex. It would radiate to the left axilla or pericardium. It's a blowing holosystolic. It may have a systolic click in character, and it's associated with a leaky mitral valve allowing blood to flow backward. Tricuspid regurgitation, again, systolic. It's in the left lower sternal border. The radiation to the left upper sternal border, again, holosystolic, and increases with inspiration, and it's a leaky tricuspid valve. Aortic regurgitation is a diastolic murmur located in the left lower sternal border at Erb's point. Right, it would radiate to the right lower sternal border if the aortic root disease is present, and it's a blowing decrescendo, decreasing in intensity, and this is a leaky aortic valve. Mitral stenosis, again, diastolic murmur. It's located at the apex, left lateral decubitus position. Radiation may have opening snap after the S2, and it's a low-pitched decrescendo rumbling. May have opening snap after S2, and it's a narrowing of the mitral valve. This is a chart just going over the various edema with depths, and then also how fast it should be rebounding to normal. And then this is a grade of the pulses. So no pulse would be absent, and you should be finding that Doppler in your clinic. 2+ is normal, easily identified, but not easily obliterated. 3+ is an increased pulse, moderate pressure for obliteration, and then 4+ is full bounding, cannot obliterate, and then 1+ is palpable but thready and weak, easily obliterated. So let's go over documentation very quickly. In your cardiovascular exam, you should be documenting heart rate and rhythm, location and character, and point of maximal impulse, presence or absence of extra heart sounds, presence or absence of any murmurs, rubs or gallops, JVP, and peripheral edema. For your peripheral vascular exam, we should be documenting presence, symmetry and quality of all major pulses, presence or absence of bruits, skin color and temperature, capillary refill, trophic changes, wounds, and then any signs of ischemia. All abnormal findings such as diminished or absent pulses, bruits, non-healing wounds, or ischemic skin changes can be clearly described and located, as these findings should prompt further diagnostic evaluation like ABI and guide management. Serial documentation is important for longitudinal follow-up, especially in patients with established peripheral artery disease, to monitor progression or complications. A good example would be like a 2 out of 6 systolic murmur, best heard at the apex. The biggest reason that you want to be very detailed in your documentation is that you should be able to document what you find, and the next person that follows you should be able to use your exam to build off of it and also locate any abnormalities that you found previously. So the key summary and takeaways is a thorough history for both systems should focus on identifying risk factors like age, diabetes, smoking, hypertension, dyslipidemia, CKD, and a family history of ASCVD. Symptoms of chest pain, dyspnea, palpitation, syncope for cardiovascular, claudication, rest pain, non-healing wounds, ischemic changes for peripheral vascular, and prior cardiovascular or vascular events. The ACC and AHA recommend systematic review of symptoms and risk factors in all patients at increased risk for peripheral artery disease and CV disease. Physical exam should include assessment of the heart rate, rhythm, heart sounds, murmurs, JVP, and peripheral edema for the cardiovascular system. For the peripheral vascular system, key elements are palpation of all major pulses, auscultation for bruits, and inspection for ischemic changes like non-healing wounds, gangrene, elevation pallor, dependent murmur, and trophic skin changes. Any abnormal findings such as diminished or absent pulses, bruits, or ischemic skin changes should prompt further evaluation with ABI to confirm PAD, and that's also recommended by the ACC and AHA. So main points: comprehensive history and physical exam are essential for early detection of CV and PVD. Abnormal findings in either symptom require further diagnostic evaluation and risk factors. risk factor modification and regular reassessment is necessary for patients with established disease to monitor progression and prevent complications. And then I have a lot of references